Yeah, it's been good. It was luckily that I did my residency clinic there, and so I kind of do the workflow, but it's different from my own. But it's fun. It's good. 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 I feel like it's already running through now. Yeah. Particular, I kind of like that, but I think so. Like, what's good? Yeah. 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 Big crowd today. There's standing. Right, how you doing? Here. Oh, yeah. I'll keep track of that. Yeah.
He's the one who's like, that is the, you know, who like ran track and so,
Yeah.
like, professional.
Test. Test.
Anyway. Our classmates were on the field before the best class. And of course, we all know what that means. Like, yeah. Guy now, since I love him. Sounds great. Oh, yeah, that sounds great. Right. Yeah. What's that?
Oh, your mask.
Good afternoon, everybody. Welcome to Grand Rounds. It's a special treat for everybody, but especially for general internal medicine to have one of our newest faculty, Mike Ramirez, speak to us today, and to have his father, his role model growing up as a physician, to be here with him as well. So I think most people know Mike. Mike went to Loyola for undergrad, but he's been a Georgetown guy ever since and joined us last July and really hit the ground running. And he's just been such a great guy to work with, a real great team player and great educator, as sure the residents that know him can attest to. So we're going to talk today about upgrades in preventative care, mostly the U.S. Preventative Services Task Force recommendations, which, are, as you know, are changing all the time. And so it's always good to have an update on that so we can all be, providing the best recommendations for preventative care for our patients. So without further ado, I'd like to introduce Mike Ramirez.
Today, we're going to be speaking about some updates in preventive care, and particularly taking a look at the guidelines that we in general internal medicine and primary care go by when we're trying to determine what we should be screening patients for. And so these are our objectives for today. We're going to first briefly touch on the concept of preventive medicine, kind of where this idea came from, the idea of screening and what we should be considering when we're creating screening tests. What is the USPSTF? So it's the United States Preventive Services Task Force. And we're going to talk about who this task force is made up by and what they do exactly to make these recommendations, how they come about reviewing the literature. We're going to talk about current grade A and B recommendations, and then dive a little bit deeper into 4 specific topics that have been changed in the last 5 years or so. We're then going to look forward to a couple of things that are in the works and likely going to be newly updated in the next year or two, and we'll end with some takeaway points. So when I was asked to give Grand Rounds and came up with this topic together with Dr. Ayub, I kind of wanted to look back to see how long has this idea of preventive medicine been a thing in the medical literature, in medical education. It seems that in the last 10, 20 years or so, a lot of people have been talking about preventive medicine versus maybe in the last 100 years, a lot of medical training has been based on treating disease after it's already occurred and not preventing it in the first place. But the idea of preventing disease being the role of the physician goes back all the way to Hippocrates, This is the second line there is a quote I found from a 13th century book of Jewish aphorisms that said, "Who is a skilled physician, he or she who can prevent sickness?" And it doesn't say cure, it says prevent. The first time I could see the term preventive medicine actually being utilized was when the Journal of Preventive Medicine was created in 1972, and this journal still exists today. So now fast forwarding to our current time and place in the world, we live in a world where we are constantly being oversaturated with information, with opinions. And I think many people, especially young people these days, are getting a lot of what they hear about their health from online, quote unquote, medfluencers, podcasts, TikToks. And they're coming to us with a lot of questions about what they should actually be concerned about, what they need to be checked for. This is further complicated by the fact that we now have abilities to map out our entire genome. You can send in a saliva sample and have your entire DNA mapped out. We have this incredible technology that exists in our world, yet we're not quite sure how to use it in the best interests of our patients. You can see here that this is the US genomics market, an estimate that it's going to continue to grow at an exponential rate over the next 5 years going into 2030. So people are buying these tests and they're coming into our clinic and asking us how to interpret them. And it's becoming a bit of a tricky situation. Some of you might have heard of these, what are called MCDs or multi-cancer detection tests that exist. And these are the three main ones that actually are available for purchase in the United States. One's called Galleri, the other CancerSeek, and the other SpotMass. All of them are similar. They essentially look for cell-free DNA from cancer cells within the bloodstream. So it's just a simple serum test that can potentially detect multiple forms of cancer. None of these are yet FDA approved, so it's all out of pocket, but some patients are purchasing these, are getting these results, and bringing them into us. So I thought maybe it would be helpful to take a step back and consider when we are going to decide to screen somebody for a certain disease, what are kind of our pillars of what goes into a screening guideline and what do we base our thought process off of when we're designing these tests. So this comes from a journal of the World Health Organization 1968 paper where they kind of said the 10 main pillars of what goes into a good screening test. So first of all, you want to be screening for something that is an important health problem, something that's actually affecting the population that you're screening, something that has potentially high morbidity or mortality, and something that is high prevalence in your screening population as well. Of course, you want, if you're going to screen for something and find it, you want to be able to treat it. So it's not necessarily helpful to screen for things that we don't have a cure for. Some patients would argue they want to know, if they're going to have like Huntington's disease, for example, you can get the genetic test for that, but we don't have a way to actually prevent it if they find out. So the question is that in their best interest or not? We want to consider the characteristics of the test itself. So we want it to be something that is highly sensitive and specific. And ideally, we want to be screening for conditions where there is a long, kind of prolonged initial phase before it turns into something more serious. So for example, like colon cancer, we know that adenomatous polyps sometimes can take up to around 10 years to turn into colon cancer. So that gives us a nice window to intervene before it develops into malignancy. We want it to be something that's cost effective, not only at the individual level, but also system-wide if we're going to be offering this to every patient. We want it to be something that's feasible, something that people actually have the ability to get done somewhat easily. We want to think about the population we're targeting. We want to make sure that we have quality assurance and risk minimization protocols in place. So making sure that it's a safe test and that, centers across the country that are going to be offering this are all offering kind of the same quality test. Of course, we want the patient to always have their own autonomy and their informed choice. So we want to make sure that it's a shared decision-making moment. And then we want to be continuously reevaluating the screening test and making sure it's up to date with the newest data. And so that's part of what we're talking about today. So what do we turn to educate us on the most recent updates in screening? Well, in primary care, one of our main sources is the United States Preventive Services Task Force, which is a bit of a mouthful. It was founded in 1984, and it is run by the Department of Health and Human Services. If you haven't heard, there is a new secretary of that branch now, so we'll see what's going to happen in the future. But it is made up of a panel of experts in primary care and preventive medicine, not just physicians, which we'll see in a second. And they release recommendations on screening tests, behavioral counseling, and preventive medications. And we're particularly going to be looking at screening tests today, not as much the other two. So if you're wondering who makes up this board, the actual putting a face to the name, you can see these are the current 16 members. They are elected by the Secretary of the HHS to serve 4-year terms. And I would draw the attention to the fact that not everybody on this slide is a physician. Some people are PhDs, some are public health experts, some are actually nurses or RNs. So there's a wide variety of representation. And I just thought it was interesting to note that the person in the top left, Wanda Nicholson, she's actually an OBGYN physician at George Washington University, so just right down the street. She's a professor of public health there. So I borrowed this nice timeline that was available on the USPSTF website, just kind of showing how much this program has grown. This task force has grown since 1984, and they posted this last year when it was their 40th anniversary in 2024. So the original task force met in 1984. It didn't meet again until 1990. With more time, it started to become a yearly and kind of constant role that everybody involved would be participating in throughout the year. They've gotten a little bit more technologically advanced. They have all these things on their website now. In 2011, they started giving annual reports to Congress. And nowadays, by 2024, or last year, they have recommendations on more than 88 topics. So what exactly are these recommendations? How do they portray them to us so that we can understand what we should be checking and what we maybe shouldn't be? Well, when you see the USPSTF recommendation on their website, they're going to give it a grade, either A, B, C, D, or I. And this is the chart that they use here. Essentially, what I want you to take away is that the A and B recommendations seem to have the best evidence behind them. They are the things that we should be checking or offering in all of our patients. They're also the things that are going to be covered by essentially all insurances. Definitely Medicare and Medicaid are actually required by the government to provide these services, and then most private insurances will follow suit as well. Grade C recommendations means there's a little bit of back and forth. There's some controversy. There seems to be some benefits to the test, also maybe some risks involved, so you should be having a shared decision-making discussion with your patient. And grade D means we really should not be testing this. The risks seem to outweigh the benefits. I essentially means there's just not enough evidence to really say one way or another. Now, I thought this would be interesting to understand exactly how these recommendations are created from the first place. So right now, any of you could actually take out your phone and go to the USPSTF.org, I believe it is, and submit a topic that you wish to be reviewed or considered for maybe making a new screening guideline. So it's open to the public 100%, and they get thousands of submissions each year. The panel of experts then comb through this. They decide what seems the most relevant and the most important thing and what maybe has changed in recent years. They then move on to stage 2, which is drafting a research plan. And this is when they recruit somebody from a group of people from Evidence-Based Practice Center, EPC. And this is usually an academic center or potentially a research center like the NIH. They put together a draft research plan and they post this online on their website. Anybody that can then go and comment on it, give feedback to it before they actually do their research and carry out that plan. They then review this evidence and make a draft recommendation, which again is posted online for public comment prior to finalizing their recommendations. So you can go online and see a lot of these things at different steps of the process, see kind of what's to come. And we're going to peek ahead at a few of those at the end of the talk. So this is a chart that I made myself, summarizing the 22 current grade A and B screening recommendations by the USPSTF. And of course, this isn't including like behavioral interventions and medications for prevention. This is just screening tests. You can see highlighted here in yellow are all of the A grade tests, so the things that have the highest evidence for them. And some of these might be a little bit surprising. I think, syphilis, screening for syphilis in sexually active teens and adults with multiple partners is a good one to keep in mind. Colorectal screening, we're going to talk more about getting your blood pressure checked once a year. So having an annual physical, that makes sense. Checking for HIV in anybody in their adult age or anybody that's pregnant, and then screening for cervical cancer. Here highlighted are the cancer screening tests that are currently grade A or B recommendations. And you might be thinking to yourself, there's one big one that's missing from this list, and that's prostate cancer. We're going to be talking a little bit about that. And then these are the topics that I want to focus in a little bit on today. We're going to take a brief look through the data as to why these updates were changed in the last 4 or 5 years since 2021. So we're going to look through osteoporosis, breast cancer screening, colorectal cancer, and lung cancer. So starting with osteoporosis. So this actually was just updated, their screening guidelines in, I believe, January 15th of last month. So it's 2025 updated recommendation. It's a grade B recommendation that in all women in our country, 65 or older, we should be offering a DEXA scan, so basically a bone density scan, to look for osteoporosis or osteopenia. And also in any postmenopausal woman who is less than 65 but has some additional risk factors. So why is this an important thing for us to be screening for? Well, we know that low bone mass or bone density leads to an increased risk of fractures and fragility fractures. And the prevalence of osteoporosis in our country is actually surprisingly high. So 12.6% of US residents greater than the age of 50 have osteoporosis, whether or not this is diagnosed or not. This is estimated, obviously. And when you look at people older than 65, it's 27% of women and 5.7% of men. I think all of us at some point during our medical training or careers have seen the psychological distress, the loss of function, and the overall morbidity and mortality that can be associated with these serious fractures. I think all of us can think of patients that have been admitted into the hospital that we've cared for after a hip fracture, for example, who have never made it home or never made it back to any quality of life that they had previously. So if this is something that we can prevent in the general population, that would be a huge advantage. So here, not to overwhelm you with a flow chart and a lot of words, but this is a look at how they actually did the literature review that went into updating their guidelines. And this is a good example kind of how all these reviews work that the USPSTF does. They essentially look at thousands of papers, randomized control trials, cohort studies, so forth. And they ultimately wean them down to what seems to be the most relevant. Here they had 145 studies in the end that they looked at. And this is some of the data put together. I'll draw your attention to this forest plot on the right side, calling your mind back to statistics class. So what we're looking at here is relative risk. And if something is close to this center line, the 1 relative risk, that means that it has just a good of chance of happening, whether they're treated with screening or with no screening, right? So you can see all of these trends here lean towards favoring screening. And we're looking here at different types of fractures. So osteoporotic fractures, major osteoporotic fractures, hip, and then this is mortality down below. Everything trended towards screening is beneficial. And you can see here absolute effect per 1,000 individuals screened. So 6 fewer people had fractures. You had 1 fewer death from an osteoporotic associated fracture out of 1,000 people. So then they also asked the question, when we diagnose osteoporosis, are our treatments safe and do they work? And the answer to both those questions seems to be yes. So here you can see that when we started someone either on bisphosphonates or on new anabolic type medicines like denosumab, they had less chance of developing fractures. They had a lower mortality, even though this does cross the one line a little bit, the 95% confidence interval. And they also seem to have similar rates of adverse effects. There was no statistical difference there. So how do we apply this in clinical practice? Well, essentially anybody who's 65, women greater than 65 in our country should be offered a DEXA scan. Anybody who's younger than that, we should be thinking about calculating a score that can help us decide whether or not we should do the DEXA. So the main one that we use, at least in Georgetown Clinic, is the FRAX score. You can use this to kind of get a percentage of their risk of fracture in the next 10 years. And if it's high enough, then you send them to get a DEXA as well. The question of how frequently this should be done. So right now, at least the USPSTF's recommendation was somewhere between every 4 to 8 years. I think in general, we do around 5 years repeating this. And then if you're wondering about where do men fall into this equation, essentially they got one of those I ratings. So there wasn't enough data to say one way or the other. So that is osteoporosis in a nutshell, screening for osteoporosis. Next, we're going to talk about screening for breast cancer. So this was updated in 2024, and it was a pretty big change. That being that it used to be we would screen people starting at age 50. This was the 2009 guidelines for breast cancer. Now we're starting at age 40. So it's a 10-year difference. The screening test of choice is doing either a mammogram or what's called digital breast tomosynthesis or 3D mammography, where essentially they just kind of take multiple X-rays of the breast from different angles and put it together into a 3D image. Doing either one of these every 2 years is the current recommendation. So why was this big change made? And why is it important? So breast cancer is the second most common cancer in our country, and the second most common cause of cancer death in U.S. women. Close to 44,000 women died of breast cancer in 2023 in the U.S. And alarmingly, the incidence in women in their 40s has been rising by about 2.0% annually from 2000 to 2015. There also seems to be some racial disparities when it comes to breast cancer in our population. So for whatever reason, Black women are 40% more likely to die of breast cancer than white. And this has even been studied in populations where they have the exact same number of mammograms and the exact same frequency between Black women and white women. Black women are more likely to be diagnosed with highly aggressive breast cancers. They're more likely to spread quickly. They're more likely to be ER, PR, and HER2 negative. So again, a lot of information on this graph, but I will draw your attention to a couple of things here. So we're looking at the breast cancer deaths that were averted. This blue bar is if you start screening in general at age 50, which is what it used to be. And then the yellowish orange bar is what you get on top of that if you start screening at age 40 in the red box there. So you can see with any screening at age 50, you save about 7 lives for 1,000 women. You get an additional 1.3 on top of that when you start screening at age 40. Of course, you're also going to have higher rates of biopsies that may not have been necessary. So that's the number of biopsies that were done that turned out to be benign. So you have 65 additional per 1,000 people. And here I thought was just a nice illustration to show that with the higher number of mammograms that a woman gets throughout her life, as long as she's doing it every 2 years from the recommended age, this correlates quite well with their life years gained and reduction in mortality. So what are we actually doing in clinical practice? Essentially, we're doing mammograms every 2 years. Now, some societies say you can do it every 1 year, including like the ACOG, American College of Gynecology. But it kind of becomes a conversation with the patient. Often sometimes people will want to do it every 1 year. But this actually includes people that have a family history of breast cancer starting at age 40. So even if they have a direct relative. It also includes patients that have dense breasts. So there's a lot of back and forth as to whether or not these patients should be getting MRIs or ultrasounds instead. The data doesn't support that as of right now. This does not include those that have high-risk genetic syndrome or BRCA. And I wanted to touch briefly on at Georgetown, confirmed this yesterday with some of our breast imagers that our standard test is digital breast tomosynthesis, so a 3D mammogram. The question of breast exams is one that comes up sometimes, and whether or not we should be doing these every year with the annual physical. Multiple societies and guidelines have said that we shouldn't be, and it shouldn't be something that we do once a year, that it often leads to overdiagnoses and false positives and a lot more stress and anxiety. So as long as someone is getting their mammograms every 2 years, the breast exam, including self-breast exams, is not recommended by the ACP or the American Cancer Society or the USPSTF. So there's breast cancer screening. Next, we're going to move on to colorectal. So this was updated in 2021, and it was another pretty big change from prior guidelines. That being, there was always a grade A recommendation that we screen in people 50 to 75. But now there's a grade B recommendation that we do screening in people starting at age 45. And remember, we basically do all of the grade B and A recommendations, and those are going to be covered by insurance. And when we talk about screening, there's 3 main options that you might have heard about. So doing a colonoscopy, right, which is kind of the gold standard. We can directly visualize what's there, remove any polyps, and prevent cancer from occurring in the first place, hopefully. If you do this and it's completely clear, you can do that every 10 years. These 2 new options here. So one is what you might know as Cologuard. You might have seen the commercials. It is a cell-free DNA test combined with basically a blood test in the stool. So the FIT test is looking for blood in the stool. So you can do that one every 3 years, or you can do just the blood test, the FIT test, every 1 year. If you do these on their set intervals, they have very similar outcomes in preventing colon cancer. So again, colorectal cancer is another very important disease to be aware of in our country. It's the 3rd leading cause of cancer death in the United States. And very similar to breast cancer, there is a rise in colorectal cancer amongst younger individuals in their 40s. Much of this is still not understood why. A lot of it, in general, a lot of why cancers are happening at a younger age is thought to be due to maybe sedentary lifestyle in the United States, maybe due to preservatives in our food and that we're not eating healthy, maybe due to microplastics. There's a lot of opinions out there. But I found it quite alarming that 1 in 10 new colorectal cancer cases are now being diagnosed in someone younger than 50. One good thing is that our rates of colorectal screening are going up, but they're not quite where we want it to be still. So as of 2020, 72.5% of people actually were up to date in colorectal screening in our country. I thought it was interesting to note, I'm not sure if anybody here knows who this individual was, but if you're a fan of superhero movies, you might know him as the Black Panther. So Chadwick Boseman was a Hollywood actor, came to fame with a Marvel movie a few years back. And unfortunately, not long after that movie, he passed away from colon cancer at just the age 43. He was diagnosed at age 40 with stage 3 colon cancer. And when this happened, it brought a lot of attention to colon cancer in younger people in our population. This map, don't get too overwhelmed by the numbers, but the takeaway is that we're looking at 2014 versus 2020. The darker areas means that rates of screening went up. So the East Coast was pretty good at increasing our rates of screening over the last decade or so. California went down a couple points, but they were already screening pretty high. And when we are discussing, what's the benefit of doing it at age 45, what I'll draw your attention to here is the options of FIT every year, Cologuard every 3rd year, or colonoscopy every 10 years. You can see that when you start screening at age 45, all of these modalities actually increase your estimated life years by about 26 years per 1,000 individuals. So it's pretty significant. And again, this is very similar looking at the number of colorectal cases that were averted. You're averting about 3 per 1,000 people. And then you're averting about 1 death per 1,000 people if you start at 45 versus 50. So the new recommendation was based on the fact that this data showed the most significant benefit in life years gained was when you started at age 45. This didn't look specifically at certain populations that we know have higher rates of colorectal cancer, such as Black or Native American populations. And again, it confirms that stool testing, so doing the FIT or the Cologuard, are viable options. But again, the most important part of this is that if either of these is positive, the patient still needs to get a colonoscopy. And you also really need to be good about doing it at the time interval that's recommended. So once you start missing a FIT scan and only doing, or a FIT test, only doing it every 2 years, the sensitivity goes way down. Now, this doesn't apply to those who have a family history of colorectal cancer, so that's an important thing to consider, or genetic disorder, or people that have prior polyps or IBD. They have their own guidelines. Some of these populations need to be getting a colonoscopy and not the other tests. But at the end of the day, choosing one of these tests or a screening modality that the patient will do is better than doing nothing at all if they're not willing to do a colonoscopy. We're starting to talk about all this at a younger age. And then the question of when should we stop screening these patients, and this applies kind of to all of the screening guidelines we're talking about. The general rule of thumb is that if somebody is expected to live another 10 years, you should still be offering them screening tests. That's obviously extremely subjective, but it comes down to a decision-making conversation with your patient. Certainly, there's some people in their upper 70s that are physiologically maybe closer to being in their 50s or 60s, and we should be thinking about screening them for colon cancer. Briefly, I just wanted to touch on, there is a serum test now for colon cancer called Septin9. It is not currently being used widely, at least that I've seen. I don't think we use this at all at Georgetown that I've seen, but it is FDA approved for colorectal cancer screening in those who are not willing to do the other forms. But there's still some controversy on this, on if it's as good at picking up kind of precancerous lesions and if there's a lot of false positives. So that's colorectal cancer. Moving on now to our last of the 4 main topics, which is lung cancer screening. So this was another pretty significant change that was recommended in 2021. Right now, anybody who is age 50 to 80 in our country that has a 20-pack year smoking history, is currently smoking or has quit within the last 15 years, is recommended to get an annual low-dose CT scan of the chest looking for nodules. And you can remember this by the 50-80-2015 rule. That is an update. It used to be the 55-80-30-15 rule. So basically, we're screening more people at a younger age, and they don't have to smoke as many cigarettes to still qualify. And I know in our practice and here at Georgetown, there's been a lot of push to be screening as many people as we can for this, as it really does work. And it's really important because lung cancer, interestingly, even though our rates of smoking in our country have dropped significantly over the last, century, it still is the #1 cause of cancer death in our country. And it's the 2nd most common cancer. In the year 2020, a significant amount of people were diagnosed and died of lung cancer in our country. And we know that the relative risk of lung cancer is 20-fold higher in those who are smokers, obviously, and that lung cancer has a poor prognosis compared to a lot of other cancers. The 5-year survival rate after being diagnosed with lung cancer on average is only 1 in 5 people are going to be alive at that 5 years. So the earlier we can pick this up and pick up these nodules and treat them, the better. So when the USPSTF was making this new recommendation, they looked at 2 major studies with a pretty significant amount of patients. So the National Lung Screening Trial, which was done in the United States and published in 2011, they looked at 53,000 some patients. And they found that the relative risk reduction in lung cancer mortality was about 20% if you started screening people with annual CT scans at age 55 versus a chest X-ray. So that was kind of one of the original ones supporting just doing a CT scan. The Nelson trial looked at people 5 years younger than that, and this was done in the Netherlands, and they found 25% lower incidence of lung cancer deaths in those that were screened with a CT scan versus not. And that's illustrated very well in this image straight from the publication. This is from the study out of the United States showing that The rates of picking up lung cancer were higher in the low-dose CT scan group, the blue line here, and the rate of dying from lung cancer was lower. And looks extremely similar in the study out of the Netherlands, and this is when they started screening even a little bit earlier at age 50. So in clinical practice, what are we considering? Obviously, if someone has a higher smoking pack year and they have an older age, these are the two most important factors we're considering in their risk of developing lung cancer. And we're counseling all these patients on smoking cessation. We do know that Black men have a higher incidence of lung cancer than white men. Interestingly, this is opposite in women, potentially due to higher prevalence of smoking in these populations, other social factors, systemic racism, and other issues with our healthcare system and our society. But it's something we should keep in mind when we're going to offer screening. We also should be thinking about environmental exposures from work and such, people that have had prior radiation and family history. So with that, those are kind of the major updates in the last 5 years for our screening guidelines. I now want to take a look at some of the guidelines that are currently in process of being updated and are probably going to be released in the coming years here. So taking a look back at this chart here, you can see that we have these different stages, and we're going to be first focusing in on a few topics that are currently developing the draft statement. So they've already gone through these first 3 steps. They have some data and they're developing their initial statement. And this is currently what's listed on the website. So you might see updates on these in the next few years. A couple of interesting topics. So coronary CT scan for cardiovascular disease screening. And then one that is in the process of being updated is prostate cancer screening. Now, this has been somewhat of a controversial topic in recent years. In 2018, the USPSTF made this a grade C recommendation, whether or not we should be doing PSA levels in patients to screen for prostate cancer. And this is in men age 55 to 69. And this is thought to be because we know many prostate cancers are slow growing. Many of them were being picked up by these PSAs, which are a very sensitive test. And many patients were getting invasive procedures like biopsies, and maybe even started on treatment, even though this cancer may not have actually had a clinical effect on them, and they might have ended up passing away from something else 10 years down the line. So right now, we basically have a conversation with our patients, and we try and figure out, do you want to do this PSA knowing the risks and benefits? But in today's world, we also know that when we check a PSA, if it's high, it doesn't automatically mean you're getting a biopsy. We know that prostate MRIs are quite useful. We have kind of guidelines in place for active surveillance that our urology colleagues utilize as well. And we also have the option of doing watchful waiting in some scenarios. So this is the flow chart straight from the research study that's being done by the USPSTF to kind of look at some of these clinical questions and see if this might need to be reframed in the next couple of years. And then in terms of things that are about to be actually released, maybe in the next year, and you can actually see their initial recommendations that are kind of the draft statements on the website right now. These are the topics. One that I think is really exciting is cervical cancer screening. So as of right now, as many of you may know, our guidelines say that we should be screening women starting at age 21 for cervical cancer. If you're in your 20s, you do just cytology. So you're looking only at the cells. You're not testing for high-risk HPV. Once someone gets in their 30s, you are looking both at cytology and looking for high-risk HPV in this population. The reason being that many of these women in their 20s are going to clear that HPV before it has a clinical effect. And you can spread it out every 5 years once you get this co-testing done. The new statement, and this is the draft that is currently on the website, so this is not yet widely accepted or official, is that women are going to be able to actually just get HPV, high-risk HPV testing instead of having to have cytology, cervical cytology. And the exciting part too is that this can actually be done theoretically just with a vaginal swab. So patients might not need to go through a pap smear, which can be obviously a very uncomfortable procedure. is a main reason why a lot of women don't stay up to date on their cervical cancer screening, just the inconvenience of all this. And as well as maybe, past sexual trauma, so forth, things making pelvic exams more difficult. Now, right now in our country, the FDA actually has approved some tests to do this that are clinician-based, so you have to do it in the office by a clinician. But they are working on, in the near future, probably releasing this so that people can even maybe do this at home, which would be a major change. So look out for this in the next few years. They're already doing some of this in Europe too. And it seems to be working pretty well. They found that, just by testing for the high-risk HPV, they prevented just as many cases of cervical cancer as doing the cytology. So that is the majority of my talk. My few takeaway points for you. So the USPSTF guidelines are what we use in primary care to decide what we should be screening for and what we shouldn't. They're evidence-based, they're expert-reviewed, and they're publicly accessible. So anybody can find these online. They're all published in JAMA, and those articles are free to access, even if you don't have a subscription. But they're also frequently changing. So we should be staying up to date and looking these things up when we're not sure what the most recent guideline is. It's really easy to see them online. The overall trend is that cancer is on the rise in younger individuals. So for most of these things, we are starting to screen earlier. But we also want to make sure it's based in fact, and that's why these research studies are done. Screening disparities are still an ongoing issue and something that needs to continue to be addressed. And then ultimately, this all comes down to making a shared decision with your patient, right? And that's why I put up this nice picture of the Georgetown quad in the springtime, hopefully soon, where you can see the sign that says Cura Personalis, which I think all of you here that are Georgetown students or residents or trained here, really everybody here should be familiar with this term at this point, which means care of the whole person. And that's what it comes down to, right? When we're talking about these topics with patients, with their family members, a lot of people bring with them certain fears or predilections, maybe based on something that they've experienced in the past, that their family has been through, just overall experiences with the healthcare system. And so we should always be taking into account kind of their personal goals, their desires and religious beliefs. And it can be helpful to involve their loved ones or family if they're willing to have them involved in the conversation. So with that, I conclude my talk. I just put a little quote here I've been reading the Dune books, which recently also was a movie, that talks about the importance of having generalists in society. They're not talking about doctors here, they're talking about like space advisors in the future, but it still applies. So thank you.